Today's ECG case is 41-year-old male with alcohol dependency presented to the general practitioner. He is not at all having any symptoms but taken an ECG. What does it mean? First, we check whether the ECG is in standardized form calibrations. Here we have one small squares and two big squares vertical and one horizontal. So the standardization is good. So it is a standard ECG. Then we can go with the rate of the ECG. First one, rate of the ECG. When you're looking at here, we could find that intervals are not clearly what we could say that it's not clearly regular. So we cannot take an equation formula of 1500 by small squares in RR interval. So you calculate the number of QRS complexes in 50 big squares and multiply it by 6. Thus we get the rate of the ECG. So here we start with from here 1, 1, 2, 3, 4. So up till here, from here to here, there are 50 big squares, and we find here that 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 small QRS complexes. So the final rate comes to be 11 into 6, which comes to be 66 beats per minute. Right, next is the rhythm. When you're looking on the rhythm of the ECG, in the lead 2, that is the long strip, lead to rhythm strip, here we can find that in the ECG strip there is the rhythm is particularly not at all regular. See here, it's not at all regular, and you can see some fibrillatory waves on the baseline, chaotic fibrillatory waves. So rhythm is not regular, or you could even say it is irregular with fibrillatory waves. So here we can differentiate between the fibrillatory as well as flutter wave that you see here. The flutter waves are more of a sawtooth pattern, but in fibrillatory is more of irregular pattern. Okay, here you can see sawtooth or undulating appearance. These are flutter waves in this form. When we look at this, these are more fibrillatory waves, no sawtooth or undulating appearance. So these are fibrillatory waves. So next we will check the axis of the ECG. Checking the axis of the ECG. Third one is axis. For checking axis, we check on the lead 1 and you check on the lead AVF. In lead 1, you see that the axis is positive. In lead AVF, you see that axis is negative. You see lead 2 also, it's positive. So nothing we say it's a normal axis, that is positive, normal axis, which range from minus 30 to plus 90. This is the normal axis. Next, now we will check the P wave. Is there any P wave abnormality here? But in the lead to rhythm strip, you cannot find any proper P wave here. So we will say that here it is P wave absent. Next, you check the QRS complex. If we check the is there any Q wave, pathological Q wave in the ECG? We check clearly that whether there is any pathological Q wave in the ECG in lead 1 or 2, lead 1, 2, 3, 4, V1, V2, V3, V4. We cannot find any pathological P wave in this ECG. So there is no pathological Q wave in this ECG. There is no pathological Q. Okay. Next comes that whether these are what about the PR interval? Since P waves are absent, it is not identifiable or not recordable. About the QRS complex, you check the QRS complex here. The lead 2, it is 1, 2, 3, 2 small squares. Not 2, it is 1, 2 small squares. Yes, right? 2 small square. So we say it's less than 120 milliseconds, so it's normal. So next we check for the ST segments. In lead 1 you check any problematic ST segment elevation is there, you check. No. Lead 2 also no. Lead 3 also no. In chest leads, no proper changes, STT changes, and you cannot find in STT changes. No. So it's normal. You find any T wave abnormality here. T wave abnormality. Could you find any T wave abnormality? Yes. In V3, it is a biphasic T wave. In V4, we could see a inverted T wave. In V5 also, in V6 also, an inverted T wave. So you can clearly write that biphasic T wave in V3 and T inversion in V4 to V6. So finally, what could come to the diagnosis here is that this is a patient, he's an alcoholic patient, alcoholic, very important, alcoholic, okay, alcoholic patient. He's unsymptomatic, he's not symptomatic, no symptoms. He had a palpitation, that's why he took Ecg. But what we check here is there is a atrial fibrillation, okay, very important, there is an atrial fibrillation. If you didn't find any P wave, there is a atrial fibrillation. And with controlled ventricular rate, because we didn't find any ventricular tachy or flutter. And you see that there is a lateral T wave inversion. That could be probably due to two reasons. Okay, the T wave inversion probably due to two reasons, like it may be ischemia, or it can be due to structural abnormalities. But here, no much symptoms of ischemia. Okay, so we'll more favor of structural abnormality. That when you check, look at the lead V1. Lead V1, you could see here that there is organized atrial activity. It could be flutter waves. You can misdiagnose it as flutter waves. Okay, flutter wave. But as I told you before, the flutter waves are more of sawtooth or undulating waves. But here it's more organized. These are quite not large enough, or they are not at all regular to tell it as a flutter wave. So it's most probably it is a fibrillatory wave. Okay, it's more of fibrillatory waves. Don't confuse it with flutter waves. So as I told, the DD can be, it's clearly it can be atrial fibrillation, and it can also be atrial flutter. But why we choose fibrillation here is that it is irregular and it is more of a fibrillatory waves. In flutter, it is regular and more like sawtooth shape waves. And also you should understand that sometimes in atrial flutter with the variable blocks, the patient can be in one rhythm for one time and in another rhythm in another time. Okay, we should also keep in mind. So we should understand finally that since the patient is an alcoholic patient, I told you it's an alcoholic patient, so it can be probably due to alcoholic cardiomyopathy. We can diagnose it as an alcoholic cardiomyopathy. Okay. And the AF is causing AF maybe due to the alcoholic cardiomyopathy. So thank you.